Hi guys, my name is Reese Anderson and I am presenting over the Affordable Care Act changes to Medicare. So a little background, in 1965, President Lyndon B. Johnson the Medicare, signed Medicare into law, creating the first public health insurance program, which was originally designed for elderly Americans. However, in 1972, Medicare eligibility was extended to Americans under the age of 65 on the basis of specified diseases and for patients who require dialysis. The law continued to, evolve and expand to include low-income patients and other various subsets of patients. In 2003, President George Bush signed what's called the Medicare Prescription Drug Improvement and Modernization Act into law, which represented an expansion of Medicare jurisdiction, creating prescription drug insurance plans funded by Medicare. The law received bipartisan support across the nation. However, gaps in coverage for medications once a predefined threshold was met resulted in some extraordinarily high costs for patients who found themselves in the coverage gap. Furthermore, prior to 2012, Medicare operated on a reimbursement model for hospitals based on how many patients were seen, which seemingly resulted in higher readmission rates due to less time spent with physicians. Finally, Medicare coverage for many preventive services was extremely limited, and as such, many patients chose to forego preventive screening prior to the changes Medicare saw with the passage of the Affordable Care Act. My essay focuses on these three key changes to Medicare, so I guess we should define what are the problems. The prescription drug coverage gap, commonly known as the donut hole, represents a monetary threshold where Medicare ceases copayments and patients are responsible for 100% of the cost of prescriptions until the total amount spent on drugs meets the definition for what is known as a catastrophic coverage. In 2006, for example, patients were responsible for a $250 deductible, after which they were responsible for 25% of the cost of medications up to $2,250, at which point they became responsible for 100% until they reached the threshold for the catastrophic coverage, which meant that patients would have to spend a total of $5,100 out-of-pocket costs, including the cost for their deductible and their co-payments, at which point Medicare covered 95% of the cost after that, and patients were only responsible for 5% co-payment. I previously mentioned these costs were prohibitively high, and they had some pretty serious adverse effects where patients were more likely to skip doses of medications or forego treatment entirely while in the coverage gap. There's an estimate from the Kaiser Family Foundation that predicted the coverage gap, so this is 2007, expected it to reach about $6,000 per year by 2016. And as such, the rapidly increasing cost of prescription drugs is one of the things that fueled the debate over the passage of the Affordable Care Act. Prior to 2011, moving on to preventive services. Prior to 2011, the Social Security Act mandated that patients were responsible for 20% of the copayment for any preventive or screening services as part of Medicare Part B. And cost sharing has always been an important tool for preventing unnecessary medical costs and driving down the cost of healthcare in general. However, there's a problem whenever we consider the fact that studies have shown that even a moderate fee for preventive or screening health services drastically reduces the likelihood of a patient utilizing them. Which can result in billions of dollars spent every year for problems that could be treated easily, or if they caught early, just treated entirely. Finally, one of the biggest criticisms of Medicare is that as a program, it's simultaneously both bloated and inefficient while wasteful of taxpayer dollars. One study showed that between 1974 and 1975, over $2.5 billion were spent on hospital readmissions within 60 days of discharge, and that's not even adjusting for inflation. Another study suggested that of the 12 million Medicare beneficiaries, approximately 20% of the patients that were admitted into hospital were likely to be readmitted within 90 days. The problem with excessive readmission is both financial and ethical, and it required action. So, what actually changed with the passage of the Affordable Care Act? It created several solutions in an attempt to close the prescription drug coverage gap. First, the bill authorizes CMS, which is the Center for Medicare and Medicaid Services, to create a prescription drug discount program by entering into agreements with pharmaceutical companies to offer manufacturer discounts for beneficiaries. Patients who found themselves in the coverage gap in 2012, for example, were entitled to a 50% discount on brand name drugs as well as 12% discount on generic drugs. So another strategy they implemented in 2011 set up a system where Medicare enrollees became decreasingly responsible for the percent of copayments while they were in the coverage gap by 7% per year from 2011 to 2019. And between 2019 and 2020, patients become responsible for 25% of the cost of prescription drugs while they are in the coverage gap. And finally, in terms of prescription drugs, the law increased the premiums paid by Medicare Part D enrollees that are high income in order to create a more equitable and enhance an equitable program and enhance the budget of the program. And so, in terms of preventative services, the Affordable Care Act included stipulations that eliminated the cost of these services for Medicare patients entirely. So that included like mammograms and pap smears and annual wellness visits and vaccinations and screenings, and the list goes on. And there's a list that's defined, or that was created by the U.S. Preventive Service Task Force, and they are the ones that decide which programs are going to be free for Medicare beneficiaries. And the implementation of this program has had some profound effects. In 2018, a study showed that women who received a screening mammogram without being responsible for any co-payments were 1.5 times more likely to utilize other screening services like pap smears and bone density tests for osteoporosis and osteopenia compared to women who didn't even partake. So moving on a little bit to the hospital readmissions reduction program, the Affordable Care Act granted the Secretary of the Center for Medicare and Medicaid Services the authority to establish what is called, what I just mentioned, the Hospital Readmissions Reduction Program, in order to incentivize hospitals to prioritize higher quality of care over quantity of care. The program penalizes hospitals that have quote-unquote excess readmission rates by decreasing the rate of reimbursement by 1% in 2013 and 2% in 2014 and 3% in 2015 and beyond, so 3% from 2015 on. The program also specifies conditions that fall into the categories of readmissions, like heart attack, heart failure, pneumonia, COPD, total hip and knee arthroplasty, as well as coronary artery bypass grafting. And those are used kind of as a test, the basis by which performance is assessed for hospitals. In 2016, prevention of even one single readmission for hospital is estimated to save between $10,000 and $58,000 in Medicare reimbursement for patients. So, how well do these programs meet their goal? Well, the changes to Medicare Part D resulted in over $20 billion saved by over 10 million patients in the 5 years from the passage of the Affordable Care Act in 2011 till the time of the report in 2016. As a result, as of 2018, the CMS reported 44.5 million individuals were enrolled in Medicare Part D plans, with 12.7 million of them receiving subsidies based on income for their prescription drugs. As of 2018, over $100 billion were accrued by Medicare and Medicaid for Part D plans, while the program really only costs about $100.1 billion, suggesting that the program is relatively, financially healthy. In terms of preventive services, the elimination of cost sharing for preventive services is concerned. Studies have shown that utilization of services is increased, now compared to before the passage of the law. However, there's lower utilization rates than we would have previously expected. Some people argue that the limiting factor to utilization of these services is due, at least in part, to the lack of knowledge regarding benefits for Medicare patients, with the exception of vaccinations, which are consistently pretty high utilization for Medicare beneficiaries who are 65 and older. While the evidence is limited, though, some studies suggest that there's a positive association between utilization of screening mammography and increased use of other services among patients who are familiar with the benefits. Optimistically, these numbers will continue to rise until a profound population benefit can be quantitatively estimated. And finally, the Hospital Readmissions Reduction Program has resulted in increased length of stay of hospitals statistically significant for patients, suggesting that there's more thorough care may be a result of the implementation of the program. From 2012 to 2015, observational studies saw a decline in readmission rates for acute myocardial infarction and pneumonia and congestive heart failure. During the 2016 fiscal year, however, over $420 million were withheld from reimbursement for hospitals that were considered underperforming across the country. And some critics, including the American Hospital Association, suggest that hospital readmission really could have nothing to do with the quality of care received, but is related to, at least in part, patient adherence to treatment programs and appropriate follow-up care. However, it seems likely that incentivizing providers to articulate the importance of post-discharge care may help decrease readmissions. And it's hard to say definitively that the program itself was the cause of decreasing readmission rates, but evidence suggests that readmission rates have dropped since the implementation of the HRRP. Overall, since the implementation of the program, both 30 and 90-day readmission rates have decreased significantly, suggesting an overall positive effect for patients. Overall, it seems to have been pretty effective. I think that's the end. Thanks for watching, guys.